All right, so general pharmacology. All right, so we're going to talk about all the meds that we as EMTs can deliver to our patients, but ultimately it's going to be up to whatever your station or company's like policies are. So we're going to talk about all these. All right. This is a term you need to know. Polypharmacy. Polypharmacy. Okay, a person who takes 5 or more medications daily. We see this a lot in our geriatric patients, especially in nursing communities, and typically those with chronic medications. It may be acute, okay? Acute medications being those are just on for a short period of time, and they're just on a bunch of medications all at once. But more often than not, we see the chronic medications. Those are on them for months to years at a time. All right, we're talking about specific effects. Okay, exactly what does the medication do to us? What is the desired effect? But even when administered appropriately, there can be side effects, and if they're administered inappropriately, we can have some dramatically serious side effects. Okay. I said policies earlier. Protocols. That was the word I was searching for. Follow your protocols. Okay, when it comes to medication that you are allowed to administer. All right, oxygen is considered a medication. You're going to see this number a lot. Okay, if the SpO2 is less than 94% in non-traumatic patients, consider oxygen. Consider oxygen therapy. Less than 95 when we see patients with shock. Okay, what is the big sign of shock that we see often? Their skin is pale, cool, clammy. Okay, we see pale, cool, clammy. Automatically, whatever the test question is talking about, I know my patient is in shock, and I want to keep their SpO2 of at least 95%. Without shock, okay? Because they can be in shock without a trauma. So 94% is what we're going to see most of the time. Okay, if it's less than 94%, we want to consider oxygen therapy. All right, oxygen is considered a medication, so it's something we need to be aware of and make sure that we know what we're doing. But it's difficult to harm somebody with oxygen, except one group that I talked about earlier. What group of patients that I talked about earlier that have a hypoxic drive, I could have problems giving them too much oxygen. COPD patients. Okay, for them, their SpO2 might range from 88 to 92%, and that might be normal and acceptable for them. So if they are having difficulty breathing, I'm giving them oxygen. But if they're just sitting there, cool, calm, and collected, and their SpO2 is 91, 92%, I'm not freaking out. Okay? Because especially when I get their information, they tell me, yeah, I have COPD, all right, I'm not worried about that as much. All right, oral glucose. That's a medication we can give for somebody that is hypoglycemic. Hypoglycemic. What does that mean? Low blood sugar, okay? So we said normal with an asterisk was between what and what? 80 and 120. Now, that asterisk is how long ago did they eat? What did they eat? Are they diabetic? These are all questions that we need to ask when we're going to be considering oral glucose. What are some signs and symptoms of somebody having a diabetic emergency of hypoglycemia? Say what? Oh, okay, we're going to get to that real quick. All right. Fatigue. What about their mental status? Decreased, okay, or altered, an altered level of consciousness. Their skin may be pale, cool, clammy. All right, pale, cool, clammy, altered level of consciousness. So Bethany talked about strokes. Okay, a stroke isn't a stroke until you rule out hypoglycemia. Okay, a stroke is not a stroke until you rule out hypoglycemia. So if they're showing all the signs and symptoms of a stroke, which are, what's one sign and symptom? Say what? No, I need more than that. Okay, drooping of what? Facial drooping. When you say muscle fatigue, are you talking about their arms? Okay, so just Sean. So that arm drift, okay, drift, or slurred speech. So facial droop, arm drift, or arm weakness, and slurred speech. Those are all signs of a stroke. But it's not a stroke until we rule out hypoglycemia. Okay, this just kind of briefly covers them. Then we're going to go in more detail. Activated charcoal. Okay, this is something that is ingested by the patient, all right, after they've ingested some type of poison in their body. If you suspect a patient has ingested something in their body that is abnormal, okay, who should you call? Poison control. Okay, have that number in your phone. Have poison control in your phone because they know everything you could possibly imagine. I had a 6-year-old that consumed bleach. Obviously, that's a pretty common one. They're going to know it. They consumed Drano. They're going to know it. Windex. They will tell you what to do and why and what you need to watch out for. Aspirin. Aspirin's for patients in chest pain. Okay, chest pain. It says may prevent complete blockage of coronary arteries by interfering with platelet function. All right, aspirin is not a blood thinner. It is an antiplatelet aggregate. Okay, so it prevents the building of your how do I back this up? Okay, it kind of injects itself in the coagulation cascade and prevents those platelets from stacking on top of each other. All right, so explaining the coagulation cascade is like a week-long course all by itself, so we're not going to get into that. But what platelets do is that when there's a cut in your skin or in the blood vessel, okay, what they do is that they deform and then they start to stick to one another, okay, creating that scab. What aspirin does is it kind of creates like a force field on it, or like imagine Teflon, okay, so they just kind of slide over each other and they can't stick to one another. All right, that's what aspirin does. Aspirin is not a blood thinner, all right, so do not confuse that. Inhaled bronchodilators. What's one that we use a lot as EMTs? Albuterol. You might also see levalbuterol. We're going to talk about dosages here in a second because those are going to be real important. We use this with a small volume nebulizer or prescribed, meter dose inhalers. Nitro. Why do we give nitro? Who do we give nitro to? That's Narcan. Nitro, who do we give it to? Cardiac patients. Okay, cardiac patients. Hypertension is a major side effect, so we're going to talk about some contraindications, just like this CPAP, where hypotension is a contraindication, so is it with nitroglycerin. All right? Now let's just talk about some of these now. If their systolic blood pressure is less than 100 millimeters of mercury, don't give it, because hypertension is a major side effect. It drops out drastically. Or if they have recently used a medication for erectile dysfunction. What are some of those? Viagra, Cialis. What's that stuff? There's like tons of commercials for it now on Twitter. Blue Chew. Okay. All those medications originally started as blood pressure medications, but they had a side effect of causing erections in men. So the pharmacies just flipped it and said, all right, we're just going to market this as an erectile dysfunction medication. That's how stuff like Viagra came about. It was originally for blood pressure, but it caused erections in men. Obviously, people didn't want to walk around with that all day, taking medication like that. So it wasn't good as a blood pressure medication, but it worked for ED. If they've been taking that within 24 hours, they cannot have nitro. What is a group of people, okay, talking demographics, that may be using ED medications and may have cardiac complications? Geriatrics, specifically in nursing homes. The rate of STDs in nursing homes has skyrocketed since the invention of Viagra. Yeah, it's unbelievable. The rate of STDs in nursing homes has skyrocketed. Okay, so just because he's a little old man, okay, looks super sweet and innocent, all right, you still gonna ask him, sir, have you taken any type of erectile dysfunction drug in the last 24 hours? Gotta ask. Otherwise, you can kill him. Epinephrine is used to treat what?
Allergic reaction.
What do we call allergic reactions? Severe ones. Anaphylaxis. Okay. Call them anaphylaxis. We're going to talk about that more in depth in a second. Naloxone, also known as Narcan, this is for opioid overdose. This is for opioid overdose. Okay. Here's the thing. It says Narcan can last about 30 to 45 minutes depending on the patient. Okay. And it's going to vary wildly here. Okay. It might not even be 30 minutes. If you had a patient that overdosed on heroin and you give them Narcan, actually, let's back up. What are some signs of opioid overdose? They may have seizures. What'd you say? You're talking about their tracks in their arms. Well, that might be something we see, but like, what? How are they going to respond? How are they going to react? You said seizures. Okay, yeah, we're going to see their pupils are going to be dilated or constricted.
Wait.
So Google it, get back to me in a second, okay? Because I want to finish this thought. Here's the big one. Respiratory depression. That's the big one in opioid overdose. Respiratory depression. Hypotension. Sedative effects. Right here. But I'm most worried about respiratory depression. Pupils are constricted, right? Okay, so our opioids are downers. They're downers. Like heroin is a downer. We see pinpoint pupils. What do you think we see in cocaine users or methamphetamine? Dilated. It's the opposite. It's the inverse. Okay, uppers, wide eyes. Downers, pinpoint eyes.
How do you treat that?
What?
Like meth and all that. Same thing, Narcan or no?
No. Okay, so Narcan only works on opioids. So heroin, like we talked about. Oh God, I'm losing them all. Morphine overdosing. Okay, only works on opioids and synthetic opioids. So what I was saying was, all right, I have a patient that I suspect has overdosed on opioids. Maybe they were having seizures. Maybe I saw those track marks. But I see respiratory depression. I see hypotension. they are not alert and oriented, I give them Narcan. Here's the danger with it. Narcan will last significantly less than the drug in their system. So if I just give them Narcan and just try to, set it and forget it, they're going to go back into respiratory depression. Okay, they're going to go back into respiratory depression. Worse than that, when you take their high away, they become violent. So any type of patient where you suspect opioid overdose, I would definitely request additional resources because it might get froggy. All right, and the last place you want to be trying to defend yourself is in the back of that truck. Okay, you can't swing on these patients. You can't. What am I trying to say? You can't secure them before they get violent, but they're probably going to get violent. So, unfortunately for EMTs, it's just a like an automatic, not injector, but there are auto injectors, but there's also the intranasal ones. Okay, you can't adjust the amount of medication you're giving them. It's just one hit, that's it. Me as a paramedic, I can adjust how much Narcan I'm giving them so they come out of respiratory depression, but I don't take them out of their high. Because once you take away their high, violence. All right, medications like ibuprofen, okay, is an NSAID, stands for non-steroidal anti-inflammatory drugs. These inhibit platelets from aggregating. This is like, what other medication we just talked about? Aspirin. It's a platelet inhibitor aggregator, okay? Here's a big thing with these medications. Do not give them if they have any gastrointestinal bleeding, any upper GI bleeds, okay? Upper GI, gastrointestinal, what are we talking about specifically? The stomach, okay? Whenever you take a Motrin, what does it say on the box? How do you take it? With what or what? Food or milk, okay? Ibuprofen says with food or milk. Why? It helps coat the stomach and prevent these ulcers. So that's one thing that happens is that if you have somebody that has a lot of ulcers, okay, and you give them ibuprofen without milk or food, it can cause that internal bleeding, that gastrointestinal bleeding. Tylenol, also known as acetaminophen, all right? We think of it as a pain reliever, but what we're going to be using it for is its antipyretic properties. Antipyretic. Pyro, what's a pyro? Fire, okay? So anti-fire, or here, heat, we're talking about fevers. What age group do you think we need to be concerned about when giving them Tylenol? What demographic might we be giving them Tylenol to reduce their fevers? Our pediatric patients, right? Yeah. So we have to be very careful about this. And let me look it up because I want to make sure I'm not saying the wrong thing here, because it could be confusing my medications, which is possible. Okay, with pediatrics, it's not that big a deal with giving them Tylenol, except giving them too much can be toxic to the liver. But backing up, aspirin, we don't give aspirin to pediatrics because it can cause Reyes syndrome. It can cause Reyes syndrome, Reyes syndrome, Reyes syndrome. Okay, so just don't give aspirin to pediatric patients. Tylenol, okay, can affect the liver. So why might I be hesitant to give Tylenol to someone that is an alcoholic? Because they may have some type of liver disease. What's another group of people or disease that I might be hesitant to give them Tylenol? Okay, if they have jaundice, which is a sign of liver failure, liver disease. What if they have hepatitis? What is hepatitis? It's an STD. Okay? You can contract it other ways. Okay? Because it's a bloodborne pathogen as well. Well, hepatitis C is a bloodborne pathogen. Okay? Hepatitis A, B, C, okay, all affect the liver. If we say HEPA or hepatic, we're talking about the liver here. So hepatitis is what? Inflammation, infection of the liver. All right. All right. This, I have a hard time saying this word. Pralidoxamine? I don't know. It doesn't matter. It's known as 2-PAM chloride. It's known as 2-PAM chloride. Okay, this comes in bundled in an auto injector called the Duodote. Okay, 2-PAM chloride and atropine. This is used often. I shouldn't say used often. It's commonly given to soldiers when they go into war zones because it can be used to fight off chemical warfare. So that's all great and dandy. Why would we need to know that as EMTs? We most commonly have to use 2-PAM chloride for organophosphate overdose, toxic exposure to organophosphates. What is an organophosphate, or what might have organophosphates in it? Think of farmers. Huh? Insecticides, pesticides, fertilizers. They have a lot of organophosphates. So all it takes is for a farmer being careless, not paying attention to the wind, and everything he's spraying or putting down is just blowing back on him. Okay? We may have to administer 2-PAM chloride and atropine. These are in auto-injector forms, okay? Yes, sir.
So is it both of them in one auto injector?
No, it's 2 separate auto-injectors. Yes. 2 separate ones. You were in the Army, right? All right, so you know what this is. It was in your pro mask. Well, probably taken out because soldiers are terrible. Okay? But, yeah. It comes with 2-PAM chloride and atropine. I doubt you're going to have any test questions over it. I doubt you're ever going to see it. It's just something to take into consideration. All right. Chemical name, generic name, trade name, official name. Know the difference for some of the basic ones, like we talked about up here, especially Tylenol. What's the trade name of oh, that is a trade name. What is the generic name of Tylenol? Starts with an A. Acetaminophen. Okay? And then Motrin, Advil, Norepinephrine. Okay, the generic name is ibuprofen. Okay, so make sure you know some of those. All right, so here's an example. Chemical name, okay, we're not worried about that. Generic name, nitroglycerin. Official name, nitroglycerin tablets, USP. Its trade name, okay, is Nitrostat. And here is an example of some of those trade names and all those. Important to know the big ones, okay? Tylenol, Motrin, nitroglycerin, albuterol. You're going to see Proventil a lot, okay? All right, now we're going to talk about the routes of medications. Okay, the routes. When we say routes, what are we talking about? The way it enters the body. Here are some of them. Sublingual is what? Under the tongue. Oral? Okay, it's ingested, it's eaten, okay? Through the mouth and into the stomach, you're eating it. Inhalation, you're breathing it in. Intramuscular, or IM, into the muscle groups. IN, or intranasal, through the nose. subcutaneous, injected under the skin into what layer? The subcutaneous layer. All right, what if I said buccal? It's not up here. What if I said buccal? Cheek. Buccal's in the cheek. And intravenous is IV. All right, sublingual, we just talked about these. We use sublingual for nitroglycerin. Nitroglycerin, whether a spray or tablet. What's the dosage of nitro? 0.3 what? 0.3 to 0.4 milligrams. This is all my medication cheat sheet, if you like. But it's always a good idea to write this stuff down, okay, so you don't forget. 0.3 to 0.4 milligrams. All right, oral medication. Use and administer aspirin, oral glucose, activated charcoal. Okay, aspirin. When I give a patient aspirin, I'm not going to tell them just to swallow the tablets. I'm going to tell them to do what before they swallow it? Chew it. Why do I want them to chew up those aspirin tablets before they swallow it? Say what? It'll act faster. Why is it going to act faster? Oh, you're crushing it. It's already broken up, so the stomach doesn't have to break down that tablet. The stomach doesn't have to break down the tablet. It's already done. You've already done that by chewing that tablet. So it will act faster. Okay? Activated charcoal is also swallowed. Okay, that binds to poisons. Some poisons, I should say. Oral glucose. All right? That's something we have our patients swallow when they're what? What condition do we give oral glucose for? Low blood sugar. Come on. We're EMTs now. Hypoglycemia. There we go. There we go. There we go. Inhaled gases, okay, or aerosols. What's one that we might inhale? Albuterol, oxygen. What's the dosage of albuterol? .5 milligrams. 2.5 milligrams. Do you guys remember lev-albuterol? We talked about that earlier. What do you think the dosage is of lev-albuterol? Huh? It is the same. It is the same. However, it only comes in 1.25 milligram vials. So you need how many? 2. So you need 2 of those vials. Whereas the albuterol comes in the 2.5 milligram vial.
Is there a difference as to why it comes in 1.5?
One is more expensive than the other. And they're produced a little differently. They're almost chemically identical. And I can't get it. I honestly don't know the answer to exactly why you'd use one over the other. But for the most part, one is lev-albuterol, much cheaper. So that's what is more commonly used. Intramuscular injection. What is a medication we as EMTs can inject into our patients? Epinephrine. What is the dosage of epinephrine? Oh, I think I heard it. 0.3 what? Milligrams. 0.3 milligrams. That's for an adult. That's for an adult. What about a pediatric patient? 0.15. You're probably going to get a test question about that. Okay? The pediatric dose for epinephrine is 0.15. How much medication is in an EpiPen? 0.3. The EpiPen has 0.3.
So then you can't use it on a child?
They may be prescribed that. But if we are administering it,
We have to draw it.
we draw it up at 0.15 milligrams. Intranasal, okay, what did I say an medication was for intranasal? Narcan, okay, Narcan. That's a medication we might administer intranasal. Subcutaneous, all right. This is it absorbs slower than our intramuscular injections. Okay, I wouldn't worry about this one too much. Yes, sir.
So intranasal, it just stays in the nose?
No, it's injected and it will go back through the nasal pharynx, past the oral pharynx, and into the body. It's going to start getting absorbed through those passageways. Medication forms. Okay, forms we're talking about. One common form is powder or tablets. We're going to see a lot of those. There's also liquids. Okay, liquid there. Here's an auto injector for Narcan. Ampules for epinephrine. Okay, we need a syringe for that. We may see gels. It comes in gel form. What comes in gel form that we give? Oral glucose. Right there is an example of it. How much do you give them? Okay, either half a tube or full tube. Half a tube or full tube. No, that's what you're giving them. Either half or full. Always follow your protocol. But if half a tube works, they start coming around. Good. Okay. Keep monitoring their glucose levels. How do we monitor their glucose levels? With a glucometer. All right, suspensions. These are medications that we have to mix. None that we're going to have to as a EMT. This is activated charcoal. Okay. Charcoal has, well, actually, that is a suspension. Activated charcoal has to be put into water and then ingested. It tastes like crap. I tried a little bit of it when I was in Iraq just to see it, and it's disgusting. All right, metered dose inhaler. What medication might we find in that? Albuterol. Okay, here we are, albuterol. We can also put them in aerosolized nebulizers. Okay, what's the dosage for albuterol? $2.5. So, have you guys already practiced this yet? The small volume nebulizer? Okay, so small volume nebulizer. Here, I got one right here. So the medication goes in here. Okay, we unscrew this and we pour the medication in here. All right, screw this back on. We connect everything like we see in the picture. Connect oxygen underneath, and we set our O2 to 6 liters per minute, and it may require up to 8. They'll start to mist in the tube. Okay, you see that misting. And we know that the medication is done when there's no longer any misting in that tube. But we can also place it on a face mask like this. Okay, so it's directly up to their face. Here, they have to hold it. But they may not be tolerant of a face mask. No, they may not tolerate a face mask, and they may have to hold it. Or they may not be able to hold it, so we have to put on a face mask. Either way. All right, gases. All right, what's one? Oxygen. Yeah, that's a big one. All right. So here we have an EMT giving her what route? Yeah. What is that device called? A nasal cannula. What's the flow rate for that? 2 to 6. All right, sprays. What's a spray that we can use as an EMT? Nitro. What's the dosages? The range. What to what? 0.3 to 0.4 milligrams. Okay, nitro for chest pain. Okay, so now we're going to talk about these a little more in depth. We're talking about indications, contraindications, dose, actions. That's the word I was looking for earlier. Couldn't find it in my head. Okay, and side effects. All right. This just describes what each of those are. Indications, why we give the meds. Contraindications, why we can't give the meds. Dose, how much. Administration route, okay, which way we're going to provide it for them. Actions, the therapeutic effect, what we want to see. The therapeutic effect is what we want to see. And side effects are often undesired actions that can occur. Okay, maybe predictable or unpredictable. Some undesired, unpredictable ones are anaphylaxis. Okay, where they have an allergic reaction to the medication because they may not know. All right, so when we get our meds, all right, ensure we have orders from med direction, okay, or we have standing protocols that just allow us. Select the proper medication, verify that's correct, check the expiration date. Here's something to take into consideration with nitroglycerin. Nitroglycerin comes in what color of a vial? Brown. Why? Protected from UV light. So, we tell our patients to store it where? In a low light environment or a dark environment. Where do you think a lot of patients store their medications? On the dresser, the nightstand, okay? And it's in the bedroom. It's almost always directly in front of the window. A side effect of nitroglycerin is hypotension, okay? It lowers your blood pressure. That's intentional, all right? With that, they typically complain of headaches. So let's say you get called to a patient that is suffering from chest pain, okay? You get there, you're doing your OPQRC and sample, you get the M, you say, what medications do you take? Or are you prescribed, et cetera, et cetera, et cetera. I take a baby aspirin every day, and I took 2 nitro tablets already. What would be a follow-up question you might have for that? If he says, I take a baby aspirin every day, and I've already taken 2 nitro tablets. Where do you store it? Can I see it? Okay, because you want to verify that it's not expired. And you can also ask them, did you get a headache? Because they typically complain about severe headaches. One dosage I didn't mention earlier was aspirin. What is the dosage of aspirin? No. We're close. 81 times what? So they come in 81 milligram tablets, and we give 4 of those bad lads for a total of what? 324 milligrams. And what we tell them to do before they swallow it? Chew it. What if he already took 1 of those 81 milligram tablets? We're going to give him 3. Okay? We're going to give him 3.
So why do they chew it first?
Say what? I didn't hear the question.
Why do they chew it up first?
We have them chew it up because that way the stomach doesn't have to break down the entire tablet. It's already broken down considerably, and it's going to get into the bloodstream much faster. All right, so we're going to check for discoloration impurities of any of their medications. Okay, we're going to check for the expiry date, make sure it's not expired, and we want to check the 5 rights. Okay, right patient, right route, right dose, right time, right reason. Yes, sir.
I can't remember what Jake was there, but they said something about 8 rights now instead of 5.
Yes, so this says 5, but there are, and it varies. It varies what book you're reading. It varies what like field you're in, because nurses have like 13. Okay, but some of the additional rights are like the right administration method, right administration site. Additional ones are like right documentation. Okay, so there's a lot of other rights involved, but your book is only asking for 5. You need to know. You need to know the 8 for your skill sheets, because you have to. One of them is small volume nebulizer, so you have to go through the 8 rights there. Okay, it says must obtain orders from med direction or have written protocols in place. All right. This is just pretty common sense. Check expiration date. Don't expire meds that are expired. Don't give discolored or cloudy meds. Verify form, route, and dose. Okay, all common sense. These are the 5 rights I was talking about. Right patient, right medication, right route, right dose, right time. Okay, also kind of reason in there. Documentation. You want to document what you gave, the route, the dosage. Okay, that's not on here, but that's important. How much you gave, what time you gave it, and any improvements, or maybe there was no improvements. All right, assess for the mental status. We're going to check their circulatory status, okay, blood pressure and skin and pulse, and we're going to check their respiratory status. All right, so you need to know this too, mental, respiratory, and circulatory, because that's also in your skill sheets. You don't need to take a photo of it. It's on your skill sheet for like small volume nebulizer is one of them. Or epinephrine administration. Okay, when you reassess, okay, you're checking all their vitals, okay? SpO2 is just part of that, changing the condition. This one this is a pretty quick review of everything. So the big thing to take away from all this is knowing the medications that you can give as an EMT. And even though on your exam, you probably don't need to know the dosages, know your dosages, especially for epinephrine. What is it for an adult? 0.3 what? Milligrams. A pediatric patient? 0.15 milligrams. I'm beating up milligrams because on your exams, especially for National Registry, you're going to see stuff like, bless you, it's going to be like 0.3 micrograms, 0.3 milligrams, 0.15 micrograms, 0.15 milligrams. What do you give for an adult? Well, it's 0.13 milligrams. But if you don't know the difference between those, you're going to be very confused, and it's going to cause you to miss that question. All right, any questions about general pharmacology?